So good morning, everyone. My name is Thivanka Witharana, and I'm an internal medical trainee currently working in London. Today, I will be presenting my project on the impact of morphine use in acute cardiogenic pulmonary edema on mortality outcomes. This is a systematic review and a meta-analysis, and I would like to start by thanking my co-authors, Dr. Baral and Professor Vassiliou, for their contributions to this project. Now, can I please also say that I'm currently suffering from a cough, so if I do cough during the presentation, please do excuse me.
Okay.
All right. Pulmonary edema is a common and a potentially fatal cause of acute respiratory failure. And a lot of the times it results from acute decompensated heart failure. And this is a result of left ventricular systolic or diastolic dysfunction. It can cause elevated cardiac filling pressures, which cause fluid buildup in the lungs, in the interstitial and the alveolar spaces. And this causes the patients to present with symptoms such as shortness of breath. So why study morphine in heart failure? Now, morphine use in heart failure dates back to the 1960s, and a lot of physicians consider this to be standard therapy, along with other medications such as diuretics and nitrates. Now, research from the 1960s and the 1980s shows that morphine has vasodilatory properties. So it decreases the venous tone and increases the peripheral venous pooling. And therefore, this in turn is thought to decrease the cardiac filling pressures. Now, what morphine does is it reduces the preload and to a certain extent, the afterload. And due to its action on the sympathetic nervous system, it's also thought to have some anxiolytic effects. So in these patients who present with acute heart failure, the effects we get are the relief of dyspnea and anxiety, which is quite useful in the acute stage. Now, it's important to note that with patients who come in with acute heart failure, they generally tend to do quite poorly in the long term. But in the short term, if we can identify this early and manage this successfully, at least we can improve the short-term outcomes. Now, with regards to morphine use in acute heart failure, despite all the good effects that we see, such as relief of dyspnea and anxiety, there are some concerns about its safety and efficacy. Now, we do know that, especially if given in large amounts and if especially given long-term, morphine can cause addiction. In addition to these, there are some other short-term side effects, such as nausea, hypotension, bradycardia, and respiratory depression. Now, we don't have any strong evidence to support or oppose the use of morphine. The European Society of Cardiology and the National Institute of Health and Clinical Excellence in the UK recommends not to use morphine routinely in acute heart failure due to these dose-dependent side effects. Now, with regards to the ESC, they recommend use of morphine as a level 2B intervention. Now, this slide here, just for reference, what level 2B interventions mean as per the European Society of Cardiology. So the usefulness and the efficacy is less well established by evidence of opinion, and therefore it may be considered in this patient group. So what existing evidence do we have? So I did a literature review, and there was a review article by Sosnowski in 2008, which was based on smaller articles, and they found a correlation between morphine use and worsening outcomes. And since then, since 2008, there's been 3 large retrospective studies. Now, the first one of which is the Peacock study, which is also part of our meta-analysis. Now, this Peacock study was a very, very big study with just under 150,000 patients. And it was based on the Acute Decompensated Heart Failure National Registry. And they found that morphine is an independent predictor of mortality after adjusting for confounders such as age and other comorbidities. The second of the 3 studies, the Gray study, they studied the effect of diuretics, opiates, and nitrate use in severe acidotic acute cardiogenic pulmonary edema, and they found no association between morphine and mortality. Now, the third study, the Lakovishvili study, which is also part of our meta-analysis, studied the use of IV morphine in acute decompensated heart failure in patients with or without acute coronary syndromes. Now, they did the analysis using multivariate analysis and propensity score analysis. Using the multivariate, they found that morphine was associated with increased mortality, however, not with the propensity score analysis. All right, so back to our study here, our systematic review meta-analysis. The aim of that was to find out whether there was a link between morphine use and acute cardiogenic pulmonary edema. And the main outcome, morphine use in acute cardiogenic pulmonary edema on patient outcomes. The main outcome that we used was, or that we looked at, was in-hospital mortality. But we also looked at some other outcomes, which I will come to in a minute. So the methods. So we carried out a literature search in October last year on PubMed and Embase. And the search terms we used were pulmonary edema spelled in different ways, or acute heart failure, and also the words morphine and mortality. To carry out our meta-analysis itself, we used the Review Manager software, and we computed odds ratio for in-hospital mortality and other clinical outcomes, and the random effect model was used. Now, this slide over here is a flow chart of the study selection process. So if we start on the left top box, it shows that from PubMed, we identified 49 studies, and from Embase, we identified 55 studies. And going down the flow chart and going to the right, you can see studies had to be excluded for various reasons. So just going back to the top, it was 49 from PubMed, 55 from Embase, and we also found 2 studies from our extensive literature search. So going down once again, reports had to be excluded for various reasons. 38 studies didn't look at the outcome of interest, i.e. in hospital mortality. 28 were not original research, and there was 1 study that was ongoing, which didn't have any data yet, so that had to be excluded as well. So finally, we were left with 6 studies for our meta-analysis. Now, these are the 6 studies that we picked. So the first one, so you can see, if you look at the right-hand column, that all the studies had looked at in-hospital mortality as one of the outcomes. But various studies had looked at other outcomes as well, some of which we were able to use in our study, but some we didn't use. So starting on the top, the CASPIO study is a retrospective observational study looking at patients presenting with acute heart failure. Now, they used propensity score matched analysis and came up with 672 patient pairs. So a total sample size of 1,344. And going down to the MIRROR study, which is a prospective study. And it's also worth noting at this point that 2 of the studies are prospective and 4 of the studies are retrospective, but they're all observational studies. Just going back to our MIRROR study here, the Spanish study, it looked at patients presenting to the emergency departments with acute heart failure, and they too used propensity score analysis and came up with 275 patient pairs. The Dominigue study, another Spanish study, they looked at in-hospital mortality as their main and only outcome. And the Lacobishvili study, which we mentioned earlier as well, when we were going through the literature review, they analyzed data from the National Heart Failure Survey. They did also use propensity score analysis. However, not all the data was available to us for our analysis, so we had to go with unadjusted data. And then the Peacock study is the next one down, which is the largest study that I mentioned earlier, with just under 150,000 patients. And finally, we have a smaller study of 276 patients by Futowski. And they studied patients hospitalized with acute pulmonary edema, and their aim was to develop a prognostic score to predict hospital outcomes. And because they looked at in-hospital mortality, we were able to use this data for our meta-analysis. Right. moving on to the interesting bit. So these are the results of our meta-analysis. Now, this slide here shows you the forest plot with all the 6 studies included, looking at in-hospital mortality as our first and main outcome. So morphine use is associated with a significant increase in in-hospital mortality. Odds ratio of 2.39 with a 95% confidence interval between 1.13 and 5.08 and a p-value of 0.02. And you can see the forest plot there showing this opposes morphine use in patients with heart failure, with acute heart failure, sorry. And then the next outcome that we looked at was the use of inotropes and vasopressors. Only 3 of our studies looked at that as one of the outcomes. So we were only able to meta-analyze using 3 of the studies. And morphine use is associated with an increased need for inotropes and vasopressor use, with the odds ratio of 2.93 there. And then the next outcome that we looked at was use of invasive ventilation. And morphine is associated once again with an increased need for invasive ventilation. Only 3 of the studies looked at that, as shown by the forest plot here. Moving on to the next outcome, and I believe that's the final outcome we looked at, use of non-invasive ventilation. Only 2 of the studies looked at that. And morphine is associated with an increased need for non-invasive ventilation as well. All right, so overall, we can see that morphine use is associated with worse outcomes. So increased in-hospital mortality, increased use of inotropes and vasopressors, increased use of invasive and non-invasive ventilation. To work with. So it's possible that the patients who were given morphine were more unwell to begin with than the patients who didn't get morphine, which may or may not have contributed to the high mortality in this patient group. Now, one might say that patients who present with acute heart failure to the emergency department are quite unwell, and it might not always be feasible to do a randomized control trial in this patient group. So there may be some ethical issues that arise that when one tries to do a randomized control trial in this patient group. And something else to bring your attention to as well. 2 of the studies that we used propensity score matched analysis. So we did a meta-analysis just using those 2 studies to find out whether morphine still had, if there was still increased in-hospital mortality in the morphine group. And that was the case. So these are the 2 studies which used propensity score analyzed data. We were able to meta-analyze just them, the CASPI and the MIRROR-O study, and they showed that morphine use, so there was high in-hospital mortality in the morphine group compared to the control group, with an odds ratio of 1.40, confidence interval of 95% confidence interval between 1.08 and 1.82, and a p-value of 0.01. So that's the forest plot of those 2 studies. And moving on, so other research in this area, there was a research by a systematic review meta-analysis by Dundam in 2021. They looked at the safety of morphine in patients with acute heart failure. Now, this study was actually quite similar to ours, especially because of how closely they were done. So our study got published in 2022 March, and this is from just last year. They also looked at in-hospital mortality, but they also looked at 7-day and 30-day all-cause mortality, along with use of invasive ventilation. And these are their results. So with regards to in-hospital mortality, there was no difference between the morphine and the control groups, which is quite interesting, because like I said, the studies were quite similar. However, the only difference was that they didn't have the Futowski study in the meta-analysis, so that may have contributed to the difference in the results we got. They also looked at 7-day all-cause mortality. Again, there was no difference between the morphine and the control group. However, they did see a significant increase in 30-day all-cause mortality and the need for invasive ventilation. So just going back to our study, it's important to talk about the limitations. So as I mentioned before, there are no randomized control trials. It's only based on observational studies. And another thing that's worth mentioning is, with regards to the morphine, we used a all or none approach. So it's difficult to say whether certain patient groups were given more morphine than the others, and if morphine dose has an effect on the outcomes. That is not something we were able to comment on in our paper. And with regards to this in-hospital mortality, we assumed everything was of cardiac origin, but that might not be the case. Evidence do suggest that heart failure-related causes are more likely in this patient group. However, with the data we had, this is not something we were able to confirm or deny. So current practice uses a therapeutic approach when it comes to morphine. We might be using a potentially harmful class of drugs in this acutely unwell patient group. So we saw in the beginning that obviously morphine does have some good effects. It relieves dyspnea and anxiety, but it also has some side effects such as nausea, bradycardia, hypotension, respiratory depression. Now, from the literature search we did, we found that some studies show negative outcomes, and some studies showed no effect from morphine use on certain outcomes. But we couldn't find any documented evidence to say that morphine has a positive effect in these patients. We just have theoretical evidence to suggest that morphine is beneficial in this patient group. Now, the American Heart Association and the American College of Cardiology recommends that morphine is only used in palliative care of end-stage heart failure. Also, for the future, it might be worth considering, there might be some alternate therapies that we can use that gives a similar effect, such as benzodiazepines, for example, in anxiety. But research is obviously needed in this area. And I would like to finish off by bringing your attention to this project that's ongoing. It's the MIMO trial, midazolam versus morphine in acute pulmonary edema, and it's a multi-center prospective randomized study. And the aim is to assess the safety of morphine in acute cardiogenic pulmonary edema. So we don't have any data yet from this study, but it will be very interesting to find out what they have to say. So watch this space. And with that, I have come to the end of my talk. Thank you very much, everyone, for listening. If anyone has any questions, then I'm happy to take them now.
Okay, thank you. Thank you for your presentation.